Welcome to the deep dive. We are tackling a really fascinating piece of source material today.
Yeah, we've got our hands on something pretty unique.
Right. It's a highly specific clinical document from the PsycNP fellowship team. It's dated March 2026.
And it's titled Managing Psychiatric Medication Side Effects, a PMHNP Clinical Decision Guide.
Which sounds super dense, but our mission today is to decode this document for you. Because honestly, reading this text is like finding the clinician's secret playbook.
It really is. It goes way beyond just a standard list of, what can go wrong.
Exactly. It's a strategic map. It details how expert prescribers proactively manage all these complex issues so patients don't just abandon their treatments.
And the intention behind this guide completely changes how we look at prescribing. I mean, a medication, no matter how brilliantly engineered it is.
Or how perfect it is for a diagnosis.
Right. It's completely useless if the patient stops taking it.
Yeah.
So side effect management is the precise arena where practitioners truly earn a patient's trust.
Okay, let's unpack this. Because when we think about modern medicine, we usually focus on that breakthrough moment,
The moment you get the prescription.
Yeah, the doctor hands it over, and there's this feeling of hope. Like, we've identified the problem, and here is the precise chemical key to unlock the solution.
But it's rarely that simple.
Oh, for sure. For anyone who has ever taken psychiatric medication or watched someone they love go through it, receiving the prescription is not the finish line.
It's really the starting line of a completely different obstacle course.
Because prescribing the right medication is only half the battle. The other half is surviving the side effects, and the guide starts with the very first hurdle you hit.
The first 14 days.
Yeah, the 2-week hurdle.
It's the immediate acute barrier. The document focuses heavily on gastrointestinal side effects during this exact window.
We're talking nausea, diarrhea, severe appetite changes.
Exactly.
Right?
These are the most common early side effects of SSRIs, SNRIs, and lithium. And the text notes this 2-week window is a massive vulnerability point.
Because it's a primary reason patients just quit. They abandon their treatment before the drugs even have a chance to affect their mood.
Which is tragic because they don't get to see the psychiatric benefits.
So if this GI distress is so common and predictable, why does it still catch patients off guard to the point of quitting? I mean, it feels almost like a hazing period for your brain chemistry, but it hits your stomach.
It does seem bizarre, right? You take a pill to fix your brain, and your stomach pays the price.
Totally bizarre.
But the biological mechanism behind that is actually incredible. Most people think of serotonin strictly as the happy chemical in the brain.
Sure, that's what we're always taught.
But biology is incredibly efficient. It reuses its tools. Nearly 90% of the serotonin receptors in the human body are not in your brain at all.
Wait, really? 90%?
Yep. They're located right in your gastrointestinal tract. Serotonin is actually a primary regulator of gut motility.
Oh, wow. So when a patient takes an SSRI designed to increase serotonin in the brain,
they are inadvertently flooding the serotonin receptors in their stomach and intestines first.
Oh, man. So the gut basically goes into overdrive.
Exactly, and interprets this sudden chemical surge as a signal to purge, resulting in, profound nausea or diarrhea.
So your stomach is literally just doing its job. It's reacting to a chemical signal that was meant for your brain.
Precisely. It's a mechanical glitch, not a punishment.
Knowing that actually makes the nausea feel way more manageable, which brings us to the psychological intervention the guide stresses, right?
Setting expectations. It's the first line of defense.
Because if a clinician tells you beforehand, hey, you will likely feel nauseous for the first 1 to 2 weeks, and then it will almost certainly fade.
As your gut receptors adapt.
Yes.
That entirely shifts the patient's psychological endurance.
You aren't just suffering endlessly. You're waiting out a known, temporary phase.
But the playbook also offers very specific, immediate clinical interventions. Like, clinicians will advise taking the medication with food to buffer the absorption.
Or they use that strategy called slow titration.
Right. Basically starting with a tiny crumb of the pill.
And slowly stepping up the dose over days or weeks to kind of sneak it past the body's alarms without triggering that massive gut reaction.
That's a perfect way to visualize it. But if the nausea is still severe despite that slow approach, the prescriber might issue a temporary antiemetic.
Like a dedicated anti-nausea medication.
Like on Danstron, just to get the patient through that acute 2-week window.
And for lithium specifically, I saw a really simple intervention the guide highlights.
Switching to an extended release version, it smooths out the absorption curve in the gut, completely changing the tolerability.
But, the guide also acknowledges that sometimes the hazing period doesn't end.
Right. Sometimes it persists.
Yeah, if those GI effects persist beyond 3 to 4 weeks and become what they call dose limiting, the strategy has to shift.
At that point, the clinician might switch to a medication with an entirely different mechanism.
They mention bupropion, or vilazodone, which is engineered specifically for better GI tolerability.
And there is even mirtazapine, which actually has intrinsic anti-nausea properties
Yeah.
built right into its chemical structure.
That is so cool. But okay, let's say you clear that first hurdle, your stomach settles down.
Then the guide moves immediately to the next phase of the obstacle course.
Decoding the fog, like what happens when a side effect doesn't fade, but instead settles over you as this persistent, heavy blanket of exhaustion?
Right. We are moving from the acute hurdles to the persistent ones, sedation and fatigue.
And the most obvious answer here, the very first step the guide mentions, is just logistical.
Move the dose to bedtime.
Yeah, take the pill when you want to sleep anyway. Simple.
But if daytime sedation persists despite that scheduling trick, the clinician has to do some serious detective work.
They can't just tell the patient to drink more coffee.
No, not at all. They have to identify the exact chemical mechanism of the fatigue because sedation isn't just one blanket response.
So looking under the hood of the medication is essential here.
Exactly. The text breaks this down into 3 primary biological pathways.
Okay, let's go through them.
First, you have antihistaminic sedation. Medications like quetiapine, mirtazapine, and trazodone strongly block histamine receptors in the brain.
And histamine promotes wakefulness, right?
Yes, so blocking it hits the patient with profound exhaustion, but the critical detail is that this type of sedation is typically strongest in the first 2 to 3 weeks.
Because the brain's histamine receptors develop a tolerance.
Right, meaning the heavy sedation might partially resolve if the patient can just push through that initial wave.
Okay, so that's the histamine blockade. But I know some of these medications also mess with your blood pressure, which feels like a completely different kind of exhaustion.
It is entirely different. That is the second pathway, alpha-adrenergic blockade.
We see this with medications like prazosin, clonidine, and certain antipsychotics, right?
Yeah, these drugs block the alpha receptors responsible for constricting blood vessels. So usually when you stand up, gravity naturally pulls your blood down towards your legs.
And your blood vessels instantly constrict to push that blood back up to your brain.
But if those receptors are blocked by the medication, the vessels don't constrict.
So the blood just stays pooled down low.
Exactly. And your brain is suddenly deprived of oxygen for a few seconds.
Wow. That mechanism causes orthostatic hypotension.
Yes. It presents as sedation, but it's fundamentally a vascular issue paired with that dangerous, dizzy feeling when standing up too fast.
And the intervention here isn't waiting for tolerance. It's often adjusting the dose or the timing to prevent falls.
Right. Safety first, and then the guide points out a third pathway, serotonergic sedation, which is often seen with higher dose SSRIs.
So this isn't the heavy knockout exhaustion of an antihistamine.
No, it is described as a subtle, persistent lethargy that just drags on the patient's functional capacity month after month.
And the intervention completely depends on which of those 3 mechanisms is at play.
Exactly. They might drop the dose, switch to a less sedating drug in the same class, or even roll out completely separate issues like sleep apnea or thyroid dysfunction.
But here is the part of the playbook that made me stop in my tracks.
The stimulants.
Yes. The guide mentions that for treatment-resistant fatigue, a clinician might strategically prescribe modafinil or armodafinil.
Wait, so sometimes the medical solution to a pill making you exhausted is giving you a powerful stimulant like modafinil.
I know, it sounds counterintuitive.
Doesn't that risk a never-ending medication cascade? Like you're taking a pill to wake up from the pill that puts you to sleep.
What's fascinating here is how carefully the text frames this. The medication cascade is a tremendous danger in psychiatry.
So they don't just hand it out lightly.
Not at all. Using modafinil is off-label, but it is supported by clinical evidence specifically for antipsychotic-induced sedation.
So it requires expert judgment.
Exactly. It's
Yeah.
a calculated trade-off. You only introduce a stimulant if you have identified the exact chemical mechanism of the fatigue.
And if the original medication is like non-negotiable.
Right. This is the crucial part. The original psychiatric medication must be providing such profound life-saving benefit for the patient's underlying condition that taking them off of it would invite a severe relapse. It's a targeted intervention. You are constantly balancing the burden of the side effect against the severity of the psychiatric condition keeping the patient alive,
It's a very delicate balance.
which perfectly sets up our next major challenge in the guide. We just talked about the heavy immobility of sedation, but the clinical document pivots sharply to the exact opposite extreme.
Akathisia.
Akathisia, an agonizing inability to stop moving. The guide describes this as an intensely distressing sensation of inner restlessness.
People are literally driven to pace endlessly,
Yeah.
rocking, shifting from foot to foot, swinging their legs.
It is most commonly caused by antipsychotics, right?
Yeah.
Specifically, aripiprazole and haloperidol are flagged.
Yes, but it can also happen with SSRIs, SNRIs, and even antiemetics.
The best way I can conceptualize it based on these descriptions is feeling like you have to sneeze, but the feeling is trapped in your entire nervous system and nobody believes you.
That is a terrifyingly accurate analogy. It's an internal physical urgency that you simply cannot satisfy.
And the danger surrounding akathisia is immense. The guide highlights this as the most misdiagnosed side effect in clinical practice,
Because it is constantly mistaken for worsening anxiety,
or an escalation of the agitation from the underlying psychiatric condition itself.
which leads to a terrible clinical scenario.
Right. A patient comes into the clinic, they can't sit still, they are practically vibrating out of their skin in distress. The doctor observes this and assumes the psychiatric condition is deteriorating,
So their logical next step is to increase the dose of the medication.
which is just pouring gasoline on a fire, because the medication is what's causing it. How on earth does a clinician actually tell the difference between the patient's underlying anxiety and this chemically induced restlessness?
Distinguishing the two is a critical skill for a prescriber, especially since akathisia is a major risk factor for treatment discontinuation and has a strong correlation with sudden suicidality.
It's life or death.
It really is. The way a clinician tells the difference relies on assessing for a concept called clear sensorium.
Meaning their cognitive state is intact.
Yes. The patient's mind is clear enough to subjectively analyze their own physical experience.
Unlike psychotic agitation, where a patient might be detached from reality or responding to internal stimuli like voices,
Or completely overwhelmed by a panic attack. A patient with akathisia can usually articulate their experience mechanically.
they'll say things like, my skin is crawling or my legs are forcing me to walk.
Right. They recognize the discomfort as an alien physical sensation imposed on them, and they often link it directly to the medication.
They can point to the pill as the culprit, even if they don't have the medical vocabulary for it.
And the guide says, once properly diagnosed, the interventions are incredibly specific.
First-line pharmacological treatment is propranolol, dosed at 20 to 40 milligrams twice daily.
They might also try a dose reduction of the offending drug or use benztropine.
In severe cases, benzodiazepines. And there are even case reports of mirtazapine and cyproheptadine showing benefit.
The takeaway is that once you recognize akathisia for what it is, you actually have the pharmacological tools to stop it.
But you have to see it first.
And observing akathisia requires the patient to be in the room, visibly moving, visibly distressed.
Which brings us to a major turn in the guide. It moves from highly visible outward symptoms to deeply private, invisible ones.
The side effects that patients actively try to hide.
The silent deal breaker, sexual dysfunction.
It's a huge issue.
The statistics laid out in this document are staggering. This affects 30 to 70% of patients taking SSRIs and SNRIs.
Decreased libido, delayed orgasm, complete anorgasmia, erectile dysfunction, reduced genital sensitivity.
Up to 70%. That is wild. And the text flat out states that this is one of the leading reasons patients ghost their prescribers.
They just disappear.
Yeah, they throw the medication away, they cancel their follow-ups, and they never tell their doctor why.
But the clinical environment itself is often to blame for this massive communication gap.
The guide is remarkably blunt about that, isn't it?
Extremely blunt. It points out that clinicians rarely ask about sexual side effects directly. They wait for the patient to volunteer the information.
Which almost never happens due to the inherent embarrassment. Is it just me? Or is it wild that the medical system relies on the patient to awkwardly bring up their sex life? Shouldn't this be standard protocol?
It absolutely should be, and that's why the guide provides a literal script for prescribers to use.
I have that script right here. It directs prescribers to proactively screen at every single follow-up, and it dictates the exact phrasing.
It says to ask. Many patients on this medication notice changes in sexual function. Have you experienced any changes in libido, arousal, or orgasm?
It doesn't just ask the question, it builds a bridge.
That phrasing is an incredibly powerful psychological tool. It utilizes social proof.
Because if a doctor simply asks, Are you having any sexual problems? It feels invasive.
Or it implies the patient is experiencing a rare personal failing. By stating first that many patients experience this, the clinician instantly removes the shame.
The issue is normalized before the patient even has to answer.
And the text notes that framing the question with this specific normalizing preamble increases patient disclosure by 3 to 4 times.
3 to 4 times, just by changing a dozen words in the clinic.
And once that secret is out and the shame is bypassed, the clinician actually has a robust toolkit to address it.
If clinically feasible, they can attempt a dose reduction. Or they can switch to a medication with a known lower risk for sexual side effects.
The guide specifically lists bupropion, mirtazapine, vilazodone, and vortioxetine as options for depression.
And there's another fascinating strategy they mention, implementing scheduled drug holidays.
Essentially having the patient skip a dose prior to sexual activity.
But crucially, the source explicitly warns against attempting this strategy with venlafaxine or paroxetine.
Yes, that is a huge warning.
Yeah.
Those specific drugs have extremely short half-lives.
So skipping a dose can trigger severe, immediate withdrawal symptoms.
It's not worth the risk. But the guide also emphasizes adding bupropion as an augmentation strategy.
Prescribing 150 to 300 milligrams of bupropion is an evidence-based method targeting sexual side effects directly, right?
Yes, it operates on dopamine and norepinephrine pathways, enhancing both libido and orgasmic function.
While simultaneously boosting the primary antidepressant effect.
It acts as a targeted countermeasure. But again, it can only be deployed if the clinician creates a safe space for the patient to admit what's happening.
So we've covered the acute adaptation of the gut, the complex mechanisms of sedation, the dangerous restlessness of akathisia, and the profound quality of life impact of sexual dysfunction.
But the final category in this clinical guide shifts our focus entirely.
Yeah, because these side effects don't just impact the quality of patient's life, they directly threaten the long-term length of life.
We're getting into the long game. Antipsychotic-induced metabolic syndrome.
The guide labels this the most clinically significant chronic side effect in psychiatric prescribing. We are talking about a cascade of severe weight gain, insulin resistance, and dyslipidemia.
The alterations to the patient's lipid profile, the massive spikes in cholesterol and triglycerides, they are silent but deadly over time.
And the guide maps out the risk profile of second-generation antipsychotics very clearly.
You have the highest risk medications, olanzapine and clozapine.
Then the moderate risk group, including quetiapine and risperidone.
And finally, the lowest risk or most weight-neutral options, which feature aripiprazole, ziprasidone, lurasidone, and cariprazine.
I want to focus on a metaphor to understand why this is so dangerous. This isn't just a side effect that makes someone a little hungrier, right?
No, it's much deeper than that.
These specific drugs, particularly olanzapine and clozapine, can fundamentally rewire the body's internal thermostat. The medication essentially tricks the metabolic system into believing the body is starving.
It alters how glucose is processed and how fat is stored.
So prevention and monitoring are the entire game here.
The text insists on strict baseline measurements before the first pill is even swallowed.
Weight, BMI, waist circumference, fasting glucose, a full lipid panel, and blood pressure.
And then repeating those at 4 weeks, 8 weeks, 12 weeks, and quarterly thereafter.
But the detail that demands attention is the early warning sign. A greater than 5% weight increase in the first month strongly predicts devastating long-term metabolic effects.
That 5% metric is crucial.
It's the canary in the coal mine for your entire metabolic system.
Hitting that 5% mark in month, one must trigger an immediate clinical intervention.
Waiting and seeing is not an option when the metabolic trajectory is established that early.
Which brings up the ultimate dilemma when reading this guide.
Yeah, if we know the precise mechanisms, if we know olanzapine carries the highest risk for basically rewiring how your body processes energy, while drugs like lurasidone carry the lowest risk, why would a clinician ever prescribe the high-risk ones in the first place?
That's a fair question.
Why not universally start everyone on the lowest risk weight-neutral option?
The answer points directly to the harsh reality of psychiatric medicine. The text emphasizes that switching medications depends entirely on clinical stability and response history.
Because psychiatry is not a discipline of universal biological responses.
Exactly. Sometimes a patient's unique neurochemistry simply does not respond to the low-risk options. A patient might cycle through 5 different weight-neutral antipsychotics while experiencing severe, terrifying psychosis.
So sometimes the drug with the heaviest, most dangerous metabolic side effects is the only chemical structure that actually stabilizes their mind.
It is a profound tightrope walk. You are balancing the brain's immediate survival against the body's long-term health.
Wow. Because pulling a patient off olanzapine to save their metabolism might trigger a devastating psychiatric relapse that they don't survive.
So instead of switching the primary drug, the clinician adds an intervention to mitigate the metabolic damage.
The guide details adding metformin.
Right, yes, at 500 to 1,000 milligrams twice daily. Metformin targets insulin sensitivity and has been shown in multiple trials to blunt antipsychotic-induced weight gain.
So you aggressively manage the metabolic side effects so you can safely maintain the life-saving benefit of the psychiatric drug.
It requires a relentless collaboration between the patient and the prescriber.
Which brings the focus of this entire document back to you, the listener.
Whether you are a patient currently navigating these complex chemical waters or a caregiver supporting someone who is.
Or simply someone fascinated by the intricate realities of human biology. Understanding these 5 categories changes your perspective.
Knowing the biological reason your gut rebels against an SSRI.
Understanding the gravity-driven mechanics of your blood pressure dropping.
Recognizing the restless trap of akathisia.
Learning the clinical script for invisible sexual dysfunction.
And watching out for that early metabolic warning sign.
It arms you. It gives you the specific vocabulary necessary to advocate for yourself or for others in a clinical setting.
The knowledge in this guide is empowering. But if we connect all of these meticulous clinical strategies to the bigger picture, there is a lingering, uncomfortable idea that echoes throughout the entire text.
What's that?
The document repeatedly notes that patients abandon their medications without telling their prescriber. They ghost the clinic.
They suffer the nausea, the fatigue, the sexual dysfunction, and the weight gain in complete silence.
Ultimately walking away from care entirely, it forces us to ask a vital question. What if one of the most formidable barriers to mental health care today isn't the underlying psychiatric condition itself?
Oh, wow. What if the true barrier is the profound silence, isolation, and stigma surrounding the side effects of the treatment?
Something to think about.
If we can't talk openly about the brutal reality of the obstacle course, we are never going to get people across the finish line.
We have to keep the conversation going.
Absolutely. Well, that wraps up our exploration of the clinician's secret playbook. Thank you for taking this deep dive with us, decoding the complex biological pathways and clinical strategies that shape modern mental health treatment. Keep talking, keep asking the hard questions, and we will catch you on the next deep dive.